Hello and welcome to A&P Live Studio. I'm your host, a registered nurse and anatomy and physiology instructor for advanced healthcare professionals. Today, we're going to be looking at a really critical condition, one that every clinician needs to have on their radar: autonomic dysreflexia. It's a hypertensive crisis that can hide in plain sight after a spinal cord injury. So here's our roadmap. We'll start with a patient in a sudden crisis. Then we'll review the body's normal autonomic balancing act to see how things should work. From there, we'll explore what happens when that communication is lost, creating a body literally divided by injury. And finally, we'll cover how to find the trigger and move our patient from a state of crisis back to control. Okay, let's jump right in where it always matters most, with the patient. This clinical scenario is going to set the stage for the physiological puzzle we're about to solve together. So picture this. You're caring for your patient, Mr. Chen. He has a high-level spinal cord injury. All of a sudden, his whole demeanor changes. He tells you he has this awful, pounding headache, and you can see he's incredibly anxious. He just has that look that tells you something is very, very wrong. You immediately take his vitals, and this is what you see: a blood pressure of 210/110. Now, for anyone, that's high. But for someone like Mr. Chen, whose baseline blood pressure might normally hang out in the 90s systolic, this is an absolute catastrophe. We're talking about a hypertensive emergency. But here's the real puzzle. While his blood pressure is through the roof, you notice his heart rate is slow. He's actually bradycardic. You have these two completely opposite signals happening at the same time. This is a huge clinical clue. So what on earth is going on here? To figure this out, we need to take a quick step back and look at the body's normal settings. And that brings us to the autonomic nervous system, the AS. You can think of it as the automatic behind-the-scenes control system that runs our internal world without us ever having to think about it. So the ANS really works through two branches that are in constant opposition. You've got the sympathetic division. That's our gas pedal, our fight or flight system. It gets the body ready for stress by constricting blood vessels and ramping up blood pressure. And then you have the parasympathetic division. That's the brake. It's our rest and digest system that slows things down to keep us calm. It's this beautiful push and pull relationship. And this constant balancing act has a name. It's called autonomic tone. Just think about how the sympathetic system maintains a tiny bit of squeeze on our blood vessels all the time. That's vasomotor tone. Or how the parasympathetic vagus nerve keeps our resting heart rate from getting too high. It's this constant dynamic tension that allows our body to make tiny, precise adjustments to keep everything stable. So what happens when that beautiful balance gets completely shattered? Well, in autonomic dysreflexia, the problem isn't really with the gas pedal or the brake itself. The problem is with the communication line between them. There's a break in the circuit. And that break typically happens with spinal cord injuries at or above the T6 vertebra. Now, why T6 specifically? Because that level is a major hub for the sympathetic nerves that control that huge network of blood vessels in our gut and abdomen. An injury there basically cuts the phone lines from the brain's control center, disabling the off switch for this massive part of the sympathetic nervous system. Let's walk through this chain reaction. It all kicks off with some kind of irritating stimulus below the level of the injury. The classic example is a full bladder. Sensory signals start traveling up the spinal cord, but they hit that roadblock at T6 and can't fully get to the brain. Instead, they trigger a massive, chaotic sympathetic reflex right there in the spinal cord. This causes a huge release of norepinephrine, which clamps down on all those blood vessels below the injury. Now, the brain does sense this crazy spike in blood pressure through its baroreceptors, and it tries to send stop signals back down. But those signals can't get past the injury. The off switch is well and truly broken. This broken circuit creates this really bizarre clinical picture. You essentially have a body that's physiologically split in two, right at the level of the spinal cord injury. And the signs and symptoms are a direct map of this internal fight. I love this quote because it paints such a clear picture. You have one part of the body, above the injury, desperately trying to calm things down, while below the injury, this sympathetic storm is just raging completely out of control. So let's look at what that actually means for the patient. So above the injury, all the signs you see are the brain's attempt to fight that hypertension. That pounding headache, that's a direct result of the high blood pressure. The brain goes all in with the parasympathetic system, causing blood vessels to dilate. That's why you see flushed skin and heavy sweating up top. And it cranks up the vagus nerve to slam the brakes in the heart, and that's the bradycardia we saw with Mr. Chen. But if you look below the level of the injury, it is a completely different story. It's all sympathetic all the time. That massive vasoconstriction makes the skin pale and cool to the touch. You'll often see piloerection, goosebumps. And since none of those rest and digest signals can get through, there's no sweating. The patient is literally hot and sweaty on top and cool and dry on the bottom. Now, understanding this pathophysiology is everything because it tells us exactly how to treat it. This is a true medical emergency, and our first goal isn't just to throw blood pressure meds at the problem, it's to find and get rid of whatever stimulus started this whole cascade. So where do we even begin to look? Well, the vast majority of the time, we're talking 85% of cases, the problem is related to the bladder or the bowel. A blocked catheter causing a distended bladder is by far the #1 culprit. And to help us remember what to look for in a hurry, we use the 6 B's mnemonic. The 6 B's give us a fantastic checklist. You always start with bladder and bowel since they're the most common offenders, but you can't stop there. It could be skin issues like pressure sores, which we call boils. It could be bones, like a fracture the patient can't even feel, or in a pregnant patient, it could even be babies. Labor itself can be a trigger. Anything that sends a painful signal from below that injury is a suspect. So the emergency protocol is incredibly logical and it's life-saving. The very first thing you do is sit the patient upright. That simple action uses gravity to help blood pool in the lower extremities, and it can bring their blood pressure down almost instantly. Next, you loosen any tight clothing. Then you start hunting for the trigger. Check the bladder first, then the bowel. And you're doing all of this while monitoring their blood pressure every few minutes. Medications really are the last resort, only used if you can't find and fix that trigger quickly. Okay, let's pull all of this together now. We've gone all the way from a stable, balanced system to a full-blown, life-threatening crisis. Let's recap this whole process. This table sums up our broken circuit story perfectly. You start in homeostasis with a balanced autonomic nervous system. Then, a spinal cord injury at T6 or higher creates that broken circuit. Some noxious stimulus from below the injury sets off an unopposed sympathetic reflex, and that's what gives us our clinical result, a hypertensive crisis with that classic reflex bradycardia. And the intervention? It's simple. Remove the stimulus, and you restore the balance. And it's so important to see this not just as a blood pressure problem, but as a crisis involving multiple systems. It all starts in the nervous system, but the cardiovascular system takes the biggest hit. The integumentary system, our skin, gives us those amazing visual clues, and the urinary and digestive systems are usually where the culprit is hiding. It's just a powerful reminder of how one little break in communication can cause a massive domino effect all through the body. When you really boil it all down, autonomic dysreflexia is just a profound and incredibly dangerous miscommunication. It takes a simple, localized problem, like a kinked catheter, and hijacks the body's own powerful alert system, turning it against itself and creating this massive systemic emergency. Being able to recognize that strange, divided clinical picture and knowing to immediately check the 6 B's can truly make the difference between control and catastrophe for your patient. Stay patho-curious, and I'll see you in the next A&P Live studio. And please remember, this video is for educational purposes only and is not a substitute for professional medical advice.